I welcome you all for today's academic activity. Today I'll be taking two crisp sessions. The agenda is to take these two sessions. First is to orient with the competency-based medical education, of which we have been implementing it since 2019. So it would be just a brush up, and the other session is on MCQs, that is a multiple choice questions. Of which also we are familiar with, but still we'll be just brushing through the presentation. So, just to begin with, I just want to emphasize a point that when we see when we prepare our resume, what we see or what the potential recruiters see is the certifications, the experience, the hard skills, or the technical skills as such. And which represents only the tip of the iceberg. So we in community medicine we have learned about the iceberg phenomenon of diseases. So this iceberg phenomenon extends to this aspect as well. And the tip of the iceberg is what we actually conventionally are qualified with. But the submerged portion of the iceberg is that which has much more skills or attributes which are equally important, more so in medical education and the healthcare profession as well. So on that note, let us have an overview of the medical education technology, competency-based medical education, and a little bit about the do's and don'ts of framing of MCQs. So the agenda for the overview for this session is to, at the end of the session, we all should be able to appreciate the need and purpose of CBME, that is competency-based medical education. Differentiate or rather try to appreciate again the difference between traditional and competency-based curriculum. We all have been a bit pessimistic or rather doubtful about this curriculum, and we also have a defense to say, so just to have a open or growth mindset and look at it with a positive aspect, and identify current updates, a few current updates, and recap about the basics of multiple choice questions and do's and don'ts. And since we know that artificial intelligence is creeping everywhere, so why not in this aspect as well, and how we can go about using MCQs or framing MCQs using artificial intelligence. Earlier, when we were trained way back, I think a decade ago, when the medical education technology or the formal training of teachers started, this was what which the presentation started as such, that we were told that this medical education also can be viewed from the concept of systems approach, which comes from the industrial science, which includes the simple process, input, outputs, and input, process, and output. So we have some inputs which is put into the raw material, which is put into the industrial process. It undergoes a certain process of manufacture, and then there is a finished product, okay, which is about to be used. So this output could be expected and actual. So expected is something which is ideal, which we want to really have, but the actual output could be different, and we need to have a feedback, so as to, or a mechanism by way of which we can get a feedback as to be able to improve the product. So this also holds good in case of medical education, wherein the raw material is the students and the teaching learning methods that we use, the curriculum that we have, and many other systems, the teachers that we have, the infrastructure that we have. All these are raw materials or inputs for the systems approach in medical education. They involve in the process of medical education, the implementation of the curriculum, and then we have a finished product of an MBBS doctor in a medical college. And then this expected outcome could be we can have MBBS graduates at par or below par. So accordingly, we need to have a system in place wherein we get a feedback to
help us know where we can do better, how we can improve, and how we can improve the product of our MBBS graduates. So this is the system. And throughput, our students now throughput म्हणतात कारण they are throughout the process of input, process and output. They are a part of all these three components of the system. That's why they are called as throughput. So the ultimate goal of MBBS education or in a medical college of modern medicine, the only then we can say that the goal has been achieved. So what are these roles? These roles, essentially these were 5 roles. There has been some 2 roles added of a critical thinker and a researcher in the 2023 CBME 2023 document, but I didn't find it in the CBME 2024 document. That is the latest document as per the graduate medical education regulations. So the first regulations came into 1997 and now we have the latest one is that of CBME 2024. So the roles are that of clinician. So this is the conventional role that all of us know. Okay, leader and team member is a role we म्हणजे आपण आत्मसात करतो when we start practicing. Okay, so this is sort of self-learned. Communicator is also learned by hidden curriculum, that is by seeing our seniors, our peers, or some role models. And lifelong learner is something again very personal, which is not formally taught or emphasized in the curriculum. And that of being a professional is being ethically sound and professional behavior, okay, in terms of behavior. So these are the roles which have been envisaged in the curriculum by as a part of CBME, in which we have to train the students formally. That means it is mandatory for us to train them to be a clinician, to be a good communicator, to be a good professional, to be a good leader and a part of a team member, and also a lifelong learner. And that is why we have, according to these, if you remember these, you will automatically align with the components of CBME, which we find very out of place or very, as if somebody has provided a lot of work on us. So this may not be the case if we appreciate these roles of the medical graduate. Another concept that we all know about, just to revise and reinforce, what is learning? So learning is, as we know, it is change in the knowledge. Conventionally, we think that learning is something what we acquire in terms of knowledge, and not necessarily in terms of behavior or even thinking. So when it comes to knowledge, it is actually the thinking that has to influence. We should start thinking differently and not just mug up certain set of books or solving certain MCQs and qualifying to certain exams. I may be a bit pessimistic or even harsh at times, but please bear with me. So knowledge is the purpose of knowledge has to be in terms of change in the thinking process of us. Also, since we are healthcare professionals and dealing with lives, so we have to also have this attitudinal change or attitudinal learning in the form of dealing with feelings, emotions, and how we really appreciate the patient or the patient's illness. And also skills, the psychomotor skills, that the technical procedures and operations and all those technical things where hands are involved. So that is learning. So it is a process resulting in some modification in the learner's way of thinking, behaving, and doing some things. So then another aspect or another concept that I want to emphasize here is that of adult learning. Because unless we हे जोपर्यंत घडी आपल्या उतरत नाही तोपर्यंत आपण आपल्या स्टुडंट्सना स्टुडंट्स आणि तुम्हाला काय अक्कल आहे असंच समजू. तर त्याच्यामुळे तो जो माइंडसेट आहे तो माइंडसेट बदलला गेला पाहिजे आणि त्याच्या अनुषंगाने आपल्याला स्टुडंट्सना पण इन्व्हॉल्व करता आलं पाहिजे. बिकॉज ॲज यू विल सी इन द लेटेस्ट स्लाइड्स, स्टुडंट्स आर ऑल्सो the important stakeholder when it comes to CBME. So how do adults learn? So adults learn by various methods. The most important, I feel, is the need to learn. I mean, I want to learn. I want to do a fellowship because I want to be, expert or master at some procedure or something. Okay. which I am passionate about. So then if I have the need to learn, only then I'll be motivated to know more about it, to go out and search literature, to read books, to find information, to have a mentor. All those things go hand in hand. So this picture kind of summarizes all the the aspects, the learning principles, adult learning principles which Malcolm Knowles has given. So he is thought to be as a pioneer of adult education. प्रौढ शिक्षणामध्ये यांनी स्वतः मला वाटतं 65व्या विकिपीडिया बघितलं तर 65व्या वर्षी वगैरे यांनी PhD केलेलं आहे. तर he was the one who brought in something called as andragogy or homogogy. So andragogy is adult learning, and he has given this 6 principles of adult learning. I don't know, but ever since I have been exposed to CBME, all I've appreciated is a few principles. Not all hold good when it comes to CBME and our the medical students as such, of which the need to learn is very, very important. Readiness to learn comes with the need, the orientation and the motivation. So these 4, I feel they are interrelated, interwoven. But these are related to core प्रौढ शिक्षण. म्हणजे त्याच्यामध्ये काय सेल्फ कॉन्सेप्ट, म्हणजे आधी आपल्याला काहीतरी अनुभव आहे. म्हणजे आता मी जसं म्हटलं फेलोशिप करायला आधी मी ऑब्स्टिट्यूशन आहे, मला त्या विषयातली गती आहे, माहिती, आय एम अ स्पेशलिस्ट इन दॅट, अँड देन नाउ आय वॉन्ट टू लर्न समथिंग मोर एक्स्ट्रा. ओके, अँड दॅट इज वाय आय हॅव अ बेसिक knowledge about the aspect that I want to learn. I just want to have some extra knowledge or extra expertise, and that is why I'm opting for that particular course or something. So this self concept is again related to adult education, and role of learner's experience. Our students, although they are adults, they are all more or less they are 18 plus. Okay, but we don't treat, we always call them students. And CBME language, MET language मध्ये we don't say students, we say learners. So our students are not really students, they are learners. So these learners experience is not really, actually I feel, this is my personal opinion, I mean you may differ, but this learners experience in my opinion is kind of not really applicable here, because प्रौढ शिक्षणामध्ये ऑलरेडी त्यांना माहिती, आपल्याला माहिती असतं आणि मग आपण जाऊन एक्स्ट्रा नॉलेज घेतो. तर हे आपल्या स्टुडंट्सना तितकंसं माहिती नसतं, पण त्यांचं रेडीनेस आणि ओरिएंटेशन आणि पुढे जाऊन ते त्यांना कसं उपयोगी पडणार आहे ह्याचं अवेअरनेस त्यांना देणं हे आपलं काम, आणि त्यासाठी त्यांना मोटिवेट करायचं. हे सगळं सांगून त्यांना मोटिवेशन विल कम only when they know why it is going to be relevant in their future practice. When they have a readiness by way of proper orientation. This is your syllabus. This is how the topics are going to be taught to you. This is how much you have to do self learning. This is about communications. This is how you have to behave with the patients, so on and so forth. I mean, there are a hell lot of things which go on. So this orientation, if it is there, so we should not have this संकुचित प्रवृत्ती की हे सगळं तुम्हाला सांगायची काय गरज आहे, तुम्ही तुमचे क्लासेस अटेंड करा आणि बाजूला आणि परीक्षा द्या. So this attitudinal change has to be brought in us as teachers. I'm sorry if I'm offending anyone, but this is why I think the medical education is kind of having all the negative influences or negative publicity or negative, I mean it has become infamous because of certain things, and these things are real, and it is high time that we become aware and we try to do something to rectify it. So that is about adult learning principles. Coming to what is CBME. So CBME, for all those who are unaware about CBME even now, it is an outcome based approach. Outcome based approach, that means we don't see at how much we have, आपलं ज्ञान मी किती पाजळलंय ह्याहीपेक्षा, सॉरी अगेन, ह्याच्याहीपेक्षा स्टुडंटला ॲज एन MBBS ग्रॅज्युएट काय येतं, okay, that is more important. So that is why it is outcome. What is the outcome is what we want our learners to know when they practice in the real world. So that is the outcome based approach, and this outcome based approach is right from the designing of the curriculum, implementation of the curriculum, assessment of the student, that is the examinations, and even evaluation of the program. Evaluation actually there needs to be a check done on how we are performing as curriculum implementers. That also check needs to be done. आणि या इव्हॅल्युएशन मध्ये पण हे आउटकम म्हणजे सगळीकडे आउटकम म्हणजे कॉम्पिटन्सी, सगळीकडे कॉम्पिटन्सी लक्षात ठेवायची. तर of a medical education program using what is called as an organized framework of competencies, and fortunately NMC has given these competencies for each subject entailing everything. So like how it is to be taught, how it is to be assessed, everything is given. So we don't have much to do there, but still these competencies need to be taken care of, or need to be taken into consideration rather, before undertaking any teaching learning activity, whether it is a field visit, whether it is a practical, whether it is a bedside clinic, whatever it is, any teaching learning session, we need to take help or look at the competency. What does the Indian medical graduate need to know, feel or do about this particular aspect of our subject? And this has to be learner centric. That means the student has to be the hero. He or she has to be the protagonist. Okay, we are side artists, supporting artists. Okay, so it is learner centric, also patient centric. Keep in mind what are patients really wanting to, what kind of care they are wanting to have. So it has to also to be patient centric, gender sensitive, outcome oriented and environment appropriate as well. So when we differentiate between the traditional curriculum and the CBME, the competency based curriculum, there are some few points I want to emphasize, and those are we emphasize more on knowledge application. How whatever he has learned, whatever I have learned in the curriculum, how can I be able to best apply it in real world practice, rather than having a whole lot of information, a rare syndrome, a name of a rare scientist or something of that sort. With due respect, I am saying this, but yes, so no, it is more of knowledge application rather than knowledge acquiring. And then it is from a little shift from teacher driven curriculum to the learner or the student driven curriculum. That means the student has to be taken into consideration at every step of teaching learning endeavors, because the student is the one who has to learn, who has to become the finished product. Okay, so they have to be comfortable with what they are learning, how they are learning, and whether they are in fact learning or not. And from non-referenced assessment to 20 लोकांचा वायवा आपण घेतोय, 20 लोकांची प्रॅक्टिकल एक्झाम आहे, त्यांच्यामध्ये जो सगळ्यात चांगला तो आपला हायेस्ट, किंवा त्यांच्यामध्ये आपण 20 पेपर्स चेक करायला घेतले, त्याच्यामध्ये जो पेपर आपल्याला चांगला वाटला तर तो हायेस्ट. आय मीन दिस इज नॉन रेफरन्स की आपण वी हॅव रॉंग, आय एम सॉरी टू से दॅट अगेन, वी आर रॉंग in terms of comparison. That is a wrong kind of a comparison. So that comparison need not be made. We have a specific criteria based on which we need to grade students. So if that criteria is met, yes, you pass. If that criteria is not met, do a remedial thing and pass. So it is not like you can't just whisk them away. You can't just write them off by saying कि तुझी तर लायकीच नाही. We can't say that. And from summative म्हणजे फायनल एक्झाम्स म्हणजे युनिव्हर्सिटी एक्झाम्सवर त्याचं मूल्यमापन करण्याच्या ऐवजी फॉर्मेटिव्ह असेसमेंट म्हणजे जेव्हा पूर्ण थ्रूआउट द करिक्युलम, थ्रूआउट द इयर और फेज दॅट द लर्नर इज स्टडिंग इन, we need to look at them, we need to track their progress and bring them on track if they lose their track. So this is the formative assessment along with the feedback. So that feedback again has to be timely. I mean, we need to give them the feedback. Okay, you are not on track, please come back on the track. Okay, you are good, you are going good, so keep it going. So both these types of feedback need to be given in a timely manner, so that they have room for rectification, so that they have a room for improvement and not suffer later. Now the actual scenario and but all what we are doing here is different. I am totally aware of that. But why not know the ideal in order to at least go above average? Okay, so let us at least know what the CBAV is trying to give us, give it to us, so that at least few of us can try to implement and experiment and try to see. So CBMA and traditional model, they are not mutually exclusive. So it doesn't mean that you leave whatever the traditional sort of a, if I may dare to say, a flaw, okay, of the traditional curriculum in terms of not having included uh, various innovative traditional methods, which like gamification or Gen Z. Okay, so it will be more appropriate for such students. And then for a competency to be achieved, okay, for this any skill that is to be achieved, it is not just one way to be achieved. They can go in the field, or they can even in the operation theater, they can during before the surgery, they can just speak to a patient and appreciate what is anxiety of the patient, what is it like going through the apprehension of going under a knife, okay, all those things. So so we should not have this what to say, kind of a tube vision, okay, to be able to approach teaching in a certain manner so that the student learns in a certain manner. There can be various ways, and we should not be offended if a student understands a YouTube video more than our lecture. Okay. So this is a curriculum which is not exactly competency based, but it is competency driven. So it is kind of taking inspiration from the competencies, hybrid into the hybridizing into a what to say, traditional model, and trying to give best of both worlds. So what is competency? We've been saying competency, competency, competency. What is competency? It is an observable, and because it is observable, hence it is measurable activity, or rather it is an ability, I would say, an observable ability of a health professional integrating multiple components like knowledge, skills, attitudes and values, and even responsiveness. Responsiveness, to understand the patient's urgency. Okay, if the patient is in pain, okay, we think it is trivial, okay, it is not going to be that life-threatening. But yes, for that patient, it is definitely bearing-wise, it is kind of life-threatening. So that responsiveness also needs to be there, and all this, if it is achieved, it is recall. If you mug up well, you are a bright student. Okay, but the same student, if the student wants to create something, okay, what is the weightage, how many marks, or how much portion of that particular competency is really important from the exam point of view. So if you are taking like for example in community medicine, epidemiology, okay, or the concept of health and disease, these are important communicable diseases, non-communicable diseases. These are the important aspects which can be tested by other methods, and there could be some other chapters or other topics or competencies rather, from which MCQs can be asked, for which MCQs can be asked. So see at the weightage as well. And then MCQs related, what type of MCQ are you going to use, could be fitting for that particular competency. Then what instructions need to be given, for example if it is a extended matching or what to say, what is that, assertion reason, then you have to give the proper instructions as well, so as to be able to understand the MCQ, understand the question. The student has to know what that student is supposed to do while answering the MCQ. And this STEM, the framing of the STEM, if it is too short, the student may not know exactly what is to be done. If it is too long, he will be losing much of the precious time in just reading the STEM. So that should not be the case. Lead-in should be very, very specific, accurate, clear, as to make the student understand what the student is supposed to be doing. And distractors should be plausible. I mean, they should be such that they should kind of be able to discriminate between the real person who has studied from the person who has guessed. So guesswork, it has to avoid guesswork. So many times we actually solve MCQs via guesswork. So what are the do's and don'ts? So general guidelines are that you plan well in advance. So the best way to plan is while you are teaching, you frame some 5-10 MCQs, which is what I do for most, not if not all, but at least most of the sessions I take. So plan right when you are teaching it so that you remember content wise your MCQ will be correct, it will be sound, and then you can revisit after a couple of days or a week or so, and then give it for peer review. So do not shy away from discussing it with your fellow colleagues and try to seek help, and this way we can help each other. And जो चुका काढेल, जितक्या जास्त चुका काढेल तो ऍक्च्युली आपल्याला MCQ रिफाईन करायला, खूप चांगला MCQ तयार करायला ऍक्च्युली indirectly मदतच करत असतो. So try, don't get offended by that. Even if there are mistakes, try to incorporate or try to rectify them as much as possible. And also do a trial run. So give those MCQs to see whether they are really doing what they are supposed to do. Then there are procedural aspects like the instructions to be given, what is the format of the MCQ, what are the levels of difficulty, formatting, and also the length. Crisp, it should be crisp, but it should not lose the clarity. So it should be unambiguous at the same time. Regarding the content, look at the learning objectives. Learning objectives. So look at the learning objectives, or rather the competency, and try to see whether it fulfills that competency, whether it is trying to get close to the competency or not. Give only important information. Have a single idea. Don't try to we should not try to ask too many things in one single MCQs. तो हावरेपणा टाळायला पाहिजे. आणि see to it by scenario based MCQs, what we encourage is higher order thinking, and also check for the student. We should not use very technical or very zard, very, what to say, polished English, or keep it simple so that the students understand. It is not an English language test. It is the medical knowledge test. So we should be wary about it. STEM construction, again, look at the format and clarity, give scenarios, sparing use of negatives, म्हणजे except किंवा not, आपण बोल्ड मध्ये ते लिहिलं तरी म्हणजे शक्यतो लिहायचंच नाही, लिहिलं तर बोल्ड मध्ये लिहायचं, जेणेकरून स्टुडंट विल नोटिस दॅट. Okay, and formatting here also it has been mentioned, and here the placement of the options, that has to be vertical and not horizontal, because horizontal असेल म्हणजे एकाच्या बाजूला एक असेल तर ते दुर्लक्ष म्हणजे होतं, ते बघितलंच जात नाही. पण एका खाली एक असेल तर चारही ऑप्शन्स, पाचही जे काही ऑप्शन्स असतील तर ते बघितले जातात, मिस होत. अँड नो विंडो ड्रेसिंग म्हणजे पूर्ण रामायण महाभारत लिहायचं आणि एवढंच काहीतरी विचारायचं, ते रामायण महाभारत वाचण्यातच स्टुडंटचा वेळ गेला तर मग they might lose out on marks and the whole purpose won't be solved. So this window dressing is also to be avoided. Developing options, you keep in the sequence, as I told. Option numbering has to be in the letters. म्हणजे ऑप्शनचा नंबर आहे तो ABCDच असावा, तो 1 2 3 4 असला, आणि समजा आपण काहीतरी बायोस्टॅटिस्टिक्सचा प्रश्न विचारतोय किंवा एखादं इयर विचारतोय किंवा नंबर ज्याच्यामध्ये आपल्याला विचारायचं आहे, पर्सेंट वगैरे असं काय, तिकडे पण नंबर असतील आणि इथे सिक्वेन्सिंगचा पण नंबर असेल तर त्या दोन्हीमध्ये कन्फ्युजन होतं. म्हणून नेहमी लेटर्स ABCD असं हे ठेवायचं. दे शुड बी इंडिपेंडेंट ऑफ इच अदर अँड ऑफ कन्सिस्टंट लेंथ, बिकॉज मेनी अ टाइम्स अवर गेसवर्क इज सगळ्यात लांबलचक जे आहे तेच खरं आन्सर. सो that is how we I mean the students get a clue, so that we have to be smarter than them. And distractors should be plausible, म्हणजे विश्वासार्ह, काय म्हणतात तसं, विश्वास बसेल असेल. So they have to be plausible and they should not be too close to the key so as to give an guess ki okay, this is only the right answer. So they should not be too close to the key. They should be very misleading, I mean not very, but they should be misleading enough so that the person who has studied will correctly answer, and the person who has not studied will not get the guesswork or will not be able to tell by guesswork. And then don'ts, avoid queuing and keeping items independent. So queuing म्हणजे आपण जेव्हा एपिडेमियोलॉजीचे क्वेश्चन्स आपण फ्रेम करतोय, मग सगळे एपिडेमियोलॉजीचेच क्वेश्चन्स एका पाठोपाठ एक, पण तोच चॅप्टर वाचले असेल तर त्याच्यामध्ये म्हणजे ते कधी कधी लक्षात येतं पटकन. सो डोंट गिव्ह, it should be like a homogeneous mix. It should be a mix of all the content of the subject. So this queuing has to be avoided. Too much over specific language also will give a clue as to what is the correct answer. Verbatim from textbooks, if they have read the textbooks, they will, in today's era, they hardly read textbooks, so maybe this might not be applicable, but who knows. So if somebody has read textbooks, they will know the answer just by knowing. For example, I kind of remember where is the word or the phrase placed in the textbook. That somehow I have that memory. So that also can be clue. Then the whole purpose is futile, because I can just remember by the way it is placed in the textbook. When it is verbatim म्हणजे काय जसं आहे तसं, जसं टेक्स्टबुक मध्ये लिहिलं गेलंय तसं. Controversial issues like related to gender or culture, religion, disability or disadvantaged groups, all those things they सगळं avoid करायचं. Tricky items that would mislead students should not be there. Too much of misleading, deception, cheating असू नये. And faulty grammar, typos, again it reflects badly on the teacher. So we need to spell check and grammatical check also we need to do. And he never and he always पण avoid करायचं. All of the above and none of the above is to be totally banned. Okay, so please do not use all of the above and none of the above, because they serve no purpose. They test nothing. Okay, they can just encourage. They can do nothing. So item analysis is the MCQ analysis. So item analysis is you test the MCQ whether it is a legible MCQ or not. Okay. So this is indicated by these three indices, and there are many more, but these are the three which are used in common parlance. So difficulty index, that is the proportion of students who have correctly answered a particular MCQ. So this is how many students have correct knowledge about the given concept. Okay, that is this index will be testing that. So if your MCQ has been answered by 75% of students, which means that the 75% of the students have correct knowledge about that particular aspect of that MCQ or concept of that MCQ. Discrimination index is the one which differentiates between high achievers and low achievers. That means those who really know and those who really, those who kind of don't. Distractor efficiency is the options. How efficient are your options in misleading the person who has not read, who has not studied. Okay.